Welcome back, ladies and gentlemen, as we embark with esteemed lineup on the thematic presentations of PEMSAC 24.
Before we commence this session, we would like to remind the speakers of the following. Each speaker will have 15 minutes to present their research. There will be one bell ring at the end of 12 minutes and two bell rings at the end of 15 minutes. Mr. Rusiru will be joining in as the timer.
Without much further ado, we would like to invite Dr. Varuni Kosgallana from the Department of Anatomy to deliver her presentation on lower limb musculature, morphology, morphometry, and evolutionary significance.
Good morning, dear sirs and madams, my colleagues and dear students. Today I am going to present to you about the lower limb musculature, the morphology, morphometry, and the evolutionary significance, focusing mainly on findings of research done at our own anatomy department. Okay, so what makes us humans different from other animals? If you are listening today morning, you might say collaboration, as Professor Maldin said, or as Dr. Manjula Peri said, what did he say? Gratitude, right? Okay, so there are differences like that. We have a bigger frontal cortex, a higher thinking capacity, and a higher level of communication compared to other organisms. But today we are going to talk about the anatomy. So, a major anatomical difference is bipedalism, that is walking on two legs. Right? So, even though other primates may be seen to be walking on two legs for shorter durations of time, only humans use bipedalism as their main form of locomotion. Right? That leaves our hands free to carry the tools we have made. Maybe phones, right? Taking calls while walking. Okay. So our center of gravity has also shifted. You can see here in the primate, it's between the upper limbs and the lower limbs. But in the humans, it is directly above the feet and the knee joint. Okay. Here also we see some differences in the primates and the humans. The above pictures are those of primates, earlier primates, and the lower pictures are those of humans. So we have a more mobile lower back as well as a shorter and wider pelvis. When we look at the lower limbs, they are longer, and the feet, they have become shorter. If we look at the muscular adaptations, the gluteus maximus muscle that has become enlarged, and its main function is to stabilize the trunk in maintaining a erect posture as well as maintaining the straight body while walking, right? In primates, it's a very small muscle and involved in propulsion mainly. And the anterior gluteus, the gluteus minimus and the medius, as well as the hamstrings, they also change their roles. Initially in the primates, it had a more propulsive role, but in the humans, it is more controlling, maintaining the body posture. The quadriceps and the plantar flexors are the main muscles which are used during for the ground reaction during walking. Then we come to one of the important muscles, interesting muscle, the peroneus tertius. It is present only in humans and few of the apes closest in the evolutionary chain. It is found in the anterior compartment of the leg and is involved in dorsiflexion along with the other anterior compartment muscles and with eversion of the foot along with the muscles in the lateral compartment. And it may be absent in some and is considered non-essential and used in tissue replacement surgeries. This image was taken at our department, at our dissection hall, and can you see the point? So here you see the peroneus tertius muscle. It starts from the lower 1/3 of the fibula extends into the fifth metatarsal head. And more proximally, you see the extensor digitorum longus muscle, starting from the proximal 2/3 of the fibula, and it has 4 tendons inserting into the 4 lateral tendons of the foot. Alright, so this is one of our research, the morphological diversity of peroneus tertius. We look to see, study different legs of our cadavers to see if there are morphological differences of these muscles. So there are some interesting variations that we found. Here the peroneus tertius muscle, it has 2 tendons. Its usual distal attachment to the head of the metatarsal bone, as well as a tendon to the fifth toe here. Right? Then the extensor digitorum longus, that had only 3 tendons to the middle 3 toes. So the lateralmost tendon of the extensor digitorum longus was replaced by a tendon from the peroneus tertius. Here was another interesting variation. It had a single muscle belly representing both the peroneus tertius and the extensor digitorum longus. Right? It had the usual distal attachments of these 2 muscles. Here we noticed the absence of peroneus tertius. This was in the left limb of a male cadaver. So all these are variations we found during our study. So if you look at a few of the important findings, the absence of peroneus tertius, it was in a minority, mind you. So we studied 54 lower limbs, and it was absent only in 1. So it was absent in 1.85%. It agrees with the available previous literature. So the absence of peroneus tertius is a minority. It is present in most of the human beings. Right? And it was absent in the left limb. Although we don't have the dominant side of the person, information on the dominant side of the person, considering the majority, if we think that it was the non-dominant limb, we could consider or think whether there's a functional significance of this finding. In previous literature also, the majority of the absences of the peroneus tertius was found in the left leg. So that raises a question which may be further studied in living persons with imaging studies, maybe for the future. Then the variations such as absence or the larger peroneus tertius muscle bar. So we saw that in some cadavers, it had replaced some of the tendons of the extensor digitorum longus, and in some, both these muscles were observed as the same muscle, right? So it may have implications during surgical procedures, like taking the muscle and tendon for the replacement surgeries, and this muscle has been implicated in stress fractures as well. So we might consider if there's a larger peroneus tertius, it may lead to the people may be prone to more stress fractures. And then the peroneus tertius muscle replacing the extensor digitorum longus and the common muscle belly. This raises the question whether the peroneus tertius and the extensor digitorum longus had a similar evolutionary origin, or is the peroneus tertius an evolutionary replacement of the extensor digitorum longus, right? So then we expanded our study for a morphometric analysis. We measured the different lengths of the muscles and the tendons to analyze if we could find any answers for our questions, right? These are the measurements we took of the peroneus tertius. I'm not going to go into detail. If you are interested, you can read about this in the Sri Lanka Anatomy Journal. So these are the measurements we took of the extensor digitorum longus. Sorry. Yes. So then we compared the muscle belly circumferences of the peroneus tertius and the extensor digitorum longus. We found a positive moderate correlation between the 2 muscles. So we thought that as the peroneus tertius became larger, the extensor digitorum longus was also larger, not smaller. peroneus tertius and the extensional digitorum longus. Here we found a mild negative correlation between the extensor digitorum longus muscle belly circumference with the number of intertendinous connections. So, if there were, when the extensor digitorum longus muscle was smaller, there were more intertendinous connections with the peroneus tertius muscle tendon. So, we can infer that these tendons are important in the distribution of forces during gait and balance and provide a supportive role as the size of the extensor digitorum longus decreases. Then we looked at the gender differences between these two muscles and tendons. So we only found a difference between the extensor digitorum longus muscle belly circumference. It was larger in the males. So usually we all know that the muscle bulk in males is larger, so it corresponds with that. But otherwise, there were no differences between the genders. So these are some of the important findings of our research. Yes, so I have come to the end of my thematic presentations, and I would like to especially acknowledge all human beings who donated their bodies for science. We are most sincerely grateful, right? We should be grateful for them. For the staff members helping to take care of these bodies, and for this particular research, Dr. Jayapati Disanaika, who guided us with immense knowledge and experience, Dr. Lakshika Navaratna from the Faculty of Science, Department of Statistics for her guidance in the statistical aspect, and Dr. Janet Pichara, who with me helped conduct this research, spending tedious hours in the dissection hall, doing the dissections and taking measurements. Okay, so future directions, maybe to define further anatomy in the living beings, imaging studies may help, and to assess the function, electromyography studies may help, and in the future maybe even robotic prosthesis. It's open to you. Okay, thank you very much. Like I said, so this research was done during my pre-intern period. Even today morning, you don't need much of resources. We don't need hi-fi stuff. We have to make use of what is available to us. We have to start from where we are. Maybe in the future we can do exceptional things, but start where you are. Okay, thank you.
Thank you, Madam. We kindly request you to please remain on stage to receive your certificate. We cordially invite Dr. Himani Amaratunga from the Department of Anatomy to award the certificate. Thank you very much. We now invite Dr. Samiti Navaratna from the Department of Community Medicine to deliver her presentation on addressing sexual health in Sri Lanka, awareness, stigma, and barriers to prevention.
Be the least prepared person for this. You know, I was rather busy during the last couple of weeks and yesterday in particular, and I managed to send in the presentation around 2 a.m. last night. So I thought of talking about a much I think is important and you know, people are reluctant to talk about this. However, addressing sexual health in Sri Lanka, the awareness, stigma, and barriers to prevention. So being a preventive specialist, I think I'm interested in prevention. And so when it comes to sexual diseases, so there's a lot of things happening in Sri Lanka, which we are aware of. So according to the slides are quite crowded, please don't get annoyed. This is not the way you should make the slides. But according to the National STD and AIDS Control Program, the prevalence of HIV in Sri Lanka is under 0.1%, indicating a low-level epidemic. So overall, the prevalence of HIV and STI remains very low across all key populations in Sri Lanka. That is according to a survey done in 2018. I have given the source. So who are these key populations we are talking about? Gay men and other men who have sex with men, which for the purpose of this presentation, I'll use MSM, the abbreviation. The commercial sex workers, male and female both. Transgender people, people who inject drugs, and prisoners and other incarcerated populations. So presence of risk behavior, including inconsistent use of condom use. You know, when it comes to prevention, what we promote is three things, the A, B and C. A is for abstinence, right? That is the best way to prevent. There's no risk at all there. The B is be faithful. You have to be faithful to one person. And C is use of condoms, right? So what we promote for these risk populations is condoms, regular, consistent use of condoms, but inconsistent usage can be a problem. And poor HIV health-seeking behavior, that is due to stigma, obviously, poor knowledge of HIV combined with poor coverage of HIV prevention programs, actually could result in an increment in the prevalence level of HIV in time to come. And as it says, we are sitting on a time bomb when it comes to HIV and STI in Sri Lanka. So, so the outline for this research plenary, I'll talk, all of the studies I'm going to cover today are kind of surveys, right? Community surveys or internet-based surveys. And the general population, we'll talk about how it is in the general population. The risk categories we talked about, the MSM particularly, and the attitudes of healthcare staff towards HIV in particular, sexual health and social networking, and sexual health among estate sector, that is, covering more disadvantaged group, I should say. Then prevention through health promotion and capacity development. That was actually a program we conducted, a TOT program. Sorry, the OT is missing here. TOT, Training of Trainers program. That is, we did with the PGIHS, that is Postgraduate Institute of Humanities and Social and Humanities, PGIHS. So that we did with the Ministry of Women and Child Affairs and Dry Zone Development. I don't know whether that ministry exists anymore because the ministry is also changed with the change of government in Sri Lanka. So I'll talk a little bit about all these things. So this general population awareness and stigma, we did a cross-sectional survey among 869 residents in Kandy to find out the awareness on HIV and AIDS, and I understand the significant knowledge gaps. And we addressed the stigma, the social problems that exist, stigma and misconceptions related to HIV and AIDS. So the key findings, so actually 93.5% were aware of HIV and AIDS, but the knowledge, the specific knowledge was not great. Okay? Only around 58.1 recognized that condoms, the usage of condoms is effective in prevention of HIV and AIDS. So then, attitude-wise, they were generally positive, but we identified that the stigma is heavily present in the population, right? So the implications the need for targeted health education to fill these knowledge gaps and reduce stigma was identified. Right. So what about the healthcare workers' attitudes? We would think that they are better, right? So the study summary, this was like we involved 114 nursing officers from the teaching hospital Peradeniya, and we explored their knowledge on the post-exposure prophylaxis and about their attitude towards HIV and particularly HIV patients, right? So only a small percentage were actually have encountered HIV patients in their working years. You know, years they were working as nursing officers. So the negative attitudes though persisted among 40.7 people. So which implicate again the training and attitude, the importance of all that, right? Because just like us, medical officers and doctors, they also need continuous development in their knowledge as well as attitudes and skills, right? Okay, moving on to sexual health and social networking. So with a click we can access many unwanted things nowadays through online channels, and we thought this is a good thing to explore, right? So this is particularly these hidden groups, the men finding sexual partners through internet facilities, right? We studied 250 MSMs recruited online, so just like in any internet-based study, we are not really sure of the, these answers they have provided, whether they are actually MSMs, so those limitations persist. However, we explored the diverse sexual orientations and high-risk sexual behaviors, barriers to accessing STD testing and treatment. And the findings, 24% claim that they are bisexual, 69% claim they are gay, right, out of the respondents, right? This is not the general population, but the 250 men who had sex with men. So risk behaviors, 67 had sex with 3 or more partners in the past year. And the barriers were significant challenges in accessing STD testing and treatment, which were again related to stigma and fear of being exposed. Healthcare preferences, nearly 90% prefer private medical practitioners. So implications from this study would be, again, need for accessible, services and stigma-free, approaches, right, from our part. Then, stigma towards people living with HIV and AIDS. This was again a study done through the internet, recruiting 130 participants, and this is general population, mind you, this is not MSMs, and we investigated the factors influencing attitudes, including the age, knowledge, and fear. What did we find? Discriminatory attitudes, 92% showed discrimination. This is the general population's attitudes, right? So they were actually affected by age. Age is the factor that affected their attitudes, the HIV-related knowledge, and fear of AIDS. So the implications, public education. Here we need the public education. needed to reduce stigma and to improve acceptance of people living with HIV and AIDS. Right, again another study, the 130 participants, and so I think this is the same one. Yes, sorry. This was again the same thing published in the EMJ. Right, so the internet using MSM, this is about 400 MSMs using internet platforms to seek other sexual partners, and the risk behaviors was 69% engaging in unsafe practices and 61 exposed that they have unprotected anal intercourse. So STI symptoms though only 9.1% reported as having experienced STI infections in the past. So the implications being internet is both a risk environment and an opportunity for, you can use it for targeted health promotion as well. Because if they are always there, then it's a place to catch them, okay, for health promotion. Right. So again the same study, but different approach. The findings were that they targeted health promotions and high number of sexual encounters via platforms were reported, and female partners, 67% had sex with female partners, right? This was again, right. And now moving on to the next part, the sexual health services in estate sector, right? A disadvantaged group. So in the summary, what we have the study summary was around, this is on 400 workers aged 18 and 24 youth, right? In Kottagala, Tarakale. So their early sexual debut, they had early sexual debut, and the mean age was like 12.56 for males. So I don't think it's through consent, right? So they were exposed to sexual activities at such a young age, and which is a true concern, right, as healthcare professionals for us. And for females, it was 16.21. So the awareness, the low awareness of HIV and STI was very, it was significantly proven through this study, and the implications is the need for integrated sexual health services tailored to youth in plantation sector. So that is what we gathered. Again, a study of 104 tea plantation workers. It also showed only 16 were aware of HIV/AIDS knowledge and 95% unaware of mother-to-child transmission. This was actually done among pregnant women and antenatal women, and they were not aware of this mother-to-child transmission. This was done about 10 to 15 years back, I guess. 2016. Okay, so, but 87% actually did not show any resistance to testing, HIV testing. However, there were concerns about stigma and confidentiality concerns. So, implications are to create again awareness among this sector, right? Okay, then again the same study, but published in regarding the mother-to-child transmission as an abstract, okay, for a conference in, I think this is Korea or somewhere, right? So the 16% were aware of HIV/AIDS and 95% unaware of mother-to-child transmission. I think it's the same. slide again, sorry. So then moving on, so we needed to identify the barriers in applying the preventive measures, and so then we did this vaginal vaginosis testing and other pregnancy outcomes. So I didn't have time actually, so I just cut and paste this whole thing and put, so I figure that you all can't see either. So there was a lot of people coming. The study involved actually 59 women, and so the bacterial vaginosis was more among married tea-plucking women actually, right? So that was the finding, and there were so many other findings in this study, so I didn't have time to put this, right? So we identified that they are socially, they think that they should approach their husbands first before getting, this themselves tested and things like that. So sorry about the slides, I was so much busy last night, so I couldn't do a proper job towards the latter end of the presentation. So that was it. And then moving on to the capacity development of members of the resource pool of Ministry of Women and Child Affairs and Dry Zone Development. So we managed to produce a book to train the trainers for prevention activities regarding sexually transmitted diseases and HIV/AIDS, and it was published by the PGIHS, this ministry, right? And we managed to actually translate it into as small booklets, usable booklets for the to Sinhala and to Tamil. So we had a program running for 3 to 4 weeks, and it was actually done as a residential course, and we gave them so many tutorials to do and activities to do, so like which is represented by this picture, things that you can do with these estate women to educate them and to promote their health and to be more comfortable when talking about the sexual related matters. Okay, so that's about it, right? So these are the references. There are so many related to this. Actually, when acknowledging, I should acknowledge other co-authors. There were several, my students, and some were done with my colleagues, one of my batchmates who are now a venerologists, and these PGIHS people who contributed to the books and development of this program. Thank you.
Thank you. We kindly request the speaker to please remain on stage to receive their certificate. We cordially invite Dr. Manjula Pires to award the certificate. Apologies. We cordially invite Professor Amal Singha to award the certificate. Thank you very much. We now invite Dr. Kasan Bandara from the Department of Forensic Medicine to deliver their presentation on Hidden in Plain Sight, Uncommon Presentations of Child Abuse.
Good morning, ladies and gentlemen. As clinicians or future clinicians, you might be the first person to encounter a case of child abuse. So, if you don't have virtual eye, you might miss it with consequences. So, in my thematic presentation titled Hidden in Plain Sight, Uncommon Presentations of Child Abuse, I will go through recent publications of many case reports and studies on uncommon presentations of child abuse presented to us, our department. I am Dr. Kasunekanagar from the Department of Forensic Medicine. As you know, a child is a person under the age of 18 years, according to UNCRC definition. Child abuse can take one or more forms of the following. It can be child physical abuse, child sexual abuse, emotional abuse, or neglect. Management of a child abuse case involves multidisciplinary approach. It involves pediatricians, pediatric surgeons, gynecology and obstetric teams, and forensic team, and also other teams such as social services and law enforcement. Rare and atypical forms of child abuse can be presented, can go unnoticed, and unless you have a watchful eye. So we will go into some case reports of uncommon presentations. So first one, we have published this in Forensic Science, Medicine and Pathology, a plastic cap inside the vagina. This 11-year-old girl presented with vaginal discharge and urinary symptoms. These symptoms were due to vesicovaginal fistula secondary to intravaginal foreign body, which was a plastic cap. You can see the silhouette of this plastic cap inside the vagina, that rectangle. This is the actual one taken out from the body, from the vagina. She had undergone vaginal penetration since the age of 6. She was 11 now. From the age of 6, she had undergone vaginal penetration forcefully by a cousin and a stepfather. She was unaware how this vaginal foreign body came into her vagina. So in the next one, we have published in the same journal, polythene bag condom. This 15-and-a-half-year-old girl following puberty, and she had an intellectual disability, and she presented with 3 to 4 months of vaginal discharge. And by the gynecology team, a polythene bag was retrieved from her vagina. This is the polythene bag. She had been vaginally penetrated on multiple occasions by her elder brother, her own brother, who used polythene bags instead of condoms. And this bag is one such bag which had been retained inside the body, leading to the vaginal symptoms. So in this case, next case, we have castration of an infant. A 9-month-old baby, male infant, presented with fresh injuries to his genital area, as you can see in this picture. And his mother admitted causing these injuries with a sharp blade. Mother had depression previously and had a diagnosis of previous schizophrenia. And she had defaulted her treatment, and she got pregnant, and no one noticed she had psychiatric issues. Aggravated by poor social support and financial issues, her condition worsened, and she and it led to this outcome. So in the next case, we have presented at the sessions of forensic pathologist. An 8-year-old girl presented by the parents who have noted skin lesions on her genital area. These lesions were small papule type nodules, tender, firm, and pinkish brown in color. And as you can see in this picture, they were diagnosed as molluscum contagiosum, which is a viral condition which can be transmitted sexually or non-sexually. Following that diagnosis, it can be prompted genital examination which revealed hymenal penetration in previous occasions. And on further inquiry, it was revealed that she was sexually abused by a known person who had been traveling in her school bus. In our next case, you know, voyeurism is a psychological condition where a person spies on sexual acts of other people. This 11-year-old schoolgirl with a poor socio-economic background presented with a history of physical abuse at home. Her class teacher had noted that she had been limping and her school performances were poor. And the injuries were compatible with repeated non-accidental blunt force trauma. And on inquiry, it was revealed that she was physically abused by her stepfather. And it was later revealed that she had been living with her mother and stepfather, and their house only had one room. And while she had been watching repeatedly her mother and stepfather having sexual intercourse, and she had been warned by the stepfather not to do that, and because she didn't stop, she had been physically assaulted. So in the next case, we have recently published this in Sri Lanka Journal of Forensic Medicine, Science and Law. An 8-year-old Buddhist monk, child monk, presented with following assault by a group of other child monks of the age ranging from 9 to 13 years. In Sri Lankan Buddhist practices, Buddhist monk should be ordained with according to the rituals, and they are usually given a certificate of ordination. This child monk did not have any of those. And his father had been moving this child from temple to temple, citing various reasons, including safety, and he had also exploited the priesthood status of this child to beg for money. And the examination, as you can see in this picture, there were some, he had dermatological conditions like skin rashes and accidental injuries, probably common in the childhood, and non-accidental injuries. As you can see in this picture, there are tram-line contusions and abrasions on the buttocks. And we have conducted a case conference at our department with the participation of a forensic team, clergy, members of the clergy, and officials from the Ministry of Buddha Sasana and Religious Affairs and the law enforcement to decide on the outcome of this child. And a case of imperforate anus for 12 years. Usually, this child was born, male child was born with imperforate anus at birth, detected by the pediatric team, and he underwent surgery, a temporary colostomy, and they had planned for reconstruction, anal reconstruction at the age of 1 month. Then the child disappeared from the records, and he appeared later at the age of 12 years. So at the age of 12 years, he had prolapse colostomy, acute abdomen, and it required emergency laparotomy and colostomy reversal and anal reconstruction. For the last previous 12 years, he had been living with the temporary colostomy. This is a picture of the imperforate anus. And he had, the guardian was his grandmother, who had neglected most of the surgical and medical care, vaccination. He was not vaccinated, and he was not provided education. And on top of that, he had been used as a beggar by the legal grandmother and other people around him. This is the case of neglect. In the next case, we have Munchausen syndrome, which is in a child, the caregiver simulates an illness in a child. So in this case, the 3-year-old boy was repeatedly investigated for hematuria from the age of 7 months, and he presented again at the age of 3 years by his mother, and doctors did the investigations. It was normal, renal biopsy normal, imagings were normal, and when the doctors asked for urine sample, when the urine sample was brought by the mother, it contained blood. When the urine sample was obtained by under supervision by the healthcare team, it didn't contain any blood. And furthermore, the urine contained bar bodies. As you know, bar body is a type of nuclear material you can see only in females. So apparently, the urine had been contaminated by the blood of his own mother. And mother had several psychiatric issues which led to this outcome. So then, Ehlers-Danlos syndrome. A 13-year-old girl, non-schooling girl, presented with multiple scars in accidental and non-accidental areas, as you can see in this picture. There was scars on the face and the upper limbs. And suspecting child abuse, she was referred to clinical forensic examination. But the child denied any history of physical abuse. Then she also had easy bruising and poor wound healing, and the pediatric team then made the diagnosis of Ehlers-Danlos syndrome, which is a condition of tissues which can lead to abnormal tissue scar formation. And since there was, they had made the clinical diagnosis correctly, and there was no suspicion of child abuse from the history or the background history, the physical child abuse was excluded. This is a case of a case where you can a clinical condition can mimic child abuse. If you don't know about this, you might suspect child abuse, and the entire family and healthcare workers might go into trouble. So these are two studies we have done on sexual abuse victims with intellectual development disorders. In this study, there were 82 sexual abuse victims. These are the profile of the victims. 42% were aged 11 to 20 years, that's mostly children, and 90% of them were female, and 53%, half of them were abused at home, and 1/4 of them were pregnant at the presentation. And about the perpetrators, 95 of them male, and almost all of them, the perpetrators were known to them, known persons. So in our last study, we have cyberbullying among adolescents. Cyberbullying is an act of bullying over electronic media. We have conducted this study with 970 school children from central province of Sri Lanka. Out of the 970 students, 4.3 claimed that they have been cyberbullied. Half of them were female, and 2/3 of them were aged 17 years, and only 10% had their own electronic devices. All others had been using electronic devices of their maybe parents or siblings. Half of them used internet only less than 2 hours. 1/3 were bullied via social media like Facebook, and most of them were bullied at night when they had access to electronic devices. And 38% were bullied by seniors of the same school, and 62% were bullied by males, and only 29% of the perpetrators were known. Other perpetrators were known. 29 were unknown, others were known to them. And almost all of them complained of sleep disturbances following bullying. So in conclusion, child abuse can present in many ways, and if you don't have a watchful eye, it can be easily missed. And individuals with learning disabilities are at higher risk of being abused, and some clinical conditions, as I mentioned before, Ehlers-Danlos syndrome can be mistaken for child abuse. So these are my references, and I would like to especially thank academic staff of our department, and especially Professor Amal Vedisinghe, whose name appears in all of these publications. Thank you very much, and this is the ribbon for prevention of child abuse. Thank you very much.
Thank you, sir. We kindly request you to please remain on stage to receive your certificate. We cordially invite Dr. Samiti Navaratna from the Department of Community Medicine to award the certificate. Thank you very much. We now invite Dr. Jayamini Srijayaratna from the Department of Anatomy to deliver her presentation on anatomical variations of the abdominal vasculature.
Good morning, my dear madams and sirs, colleagues, and dear students. So, it's anatomy again, okay? Now, it's about anatomical variations of the abdominal vasculature. Now, this is the normal anatomy of the abdominal vasculature. So, there are two main vessels, the abdominal aorta and the inferior vena cava. So, both of them are centrally placed, lying on the posterior abdominal wall with many of their branches and tributaries, but with the vein usually on the right side of the artery. So let's talk about the abdominal aorta and its branches first. So the abdominal aorta starts when passing behind the median arcuate ligament and between the crura of the diaphragm on the front of the body of thoracic vertebra. Then it goes down and divides into the two common iliac arteries on the body of L4 vertebra, as you can see in this picture. So here you have several branches, some are ventrally placed, some are paired. So let's talk about those branches. So there are three anterior visceral branches. Those are celiac artery, superior mesenteric artery, and the inferior mesenteric artery. All these three arteries gives several branches to your intestines. So there are many variations in these arteries, and that is why today we are talking about the normal anatomy and the variations of these branches. So as you can see in this graph, see all these three arteries gives off several branches, and those branches again gives off another branches, supplying the parts of the gut and the alimentary canal and the other derivatives of the alimentary canal. And then the abdominal aorta has three lateral visceral branches. What are those? Suprarenal artery, renal arteries, testicular or ovarian artery, or we call it gonadal arteries. Then there are 5 lateral abdominal wall branches, inferior phrenic and 4 lumbar. So then again it has 3 terminal branches. So we usually talk about the main terminal branches, the 2 common iliacs, but there is one midline artery, the median sacrum. So all these branches comprise the posterior abdominal wall vasculature and the abdominal vasculature, arterial supply. Let's go to the inferior vena cava. So it begins opposite the L5 vertebra and pierces the central tendon of the diaphragm at the level of the body of T8 vertebra. So usually what we learn, veins follow the course of arteries, and usually we remember if an artery has a branch, the corresponding vein also has the same name carrying a tributary. Okay, but here that is different. Tributaries of the inferior vena cava are not identical to the branches of the abdominal aorta. Why is that? Because the blood from the gut and its derivatives are collected from the portal venous system. So that is the difference. And this blood from the gut and its derivatives, they are collected from the portal venous system and then goes to the liver and sinusoids, and then they are collected from the hepatic veins and then drain into the inferior vena cava. So that is the portal venous system. So let's go to the systemic venous system in the abdominal neck. So there we have 3 lateral visceral tributaries. What are those? Right suprarenal vein, then renal veins, then right testicular and ovarian vein. So then what happened to the left suprarenal and left testicular or ovarian vein? The common happening is both of them drain into the left renal vein. So that is a place where we can see some variation. If you look into your cadaver at the anatomy dissection hall, very carefully you will be finding those variations. Then there are 5 lateral abdominal wall tributaries. What are those? Inferior penic vein and 4 lumbar veins. Then there are 3 tributaries of origin. The main 2 common iliac veins, then the medial sacral vein. Okay. So now let's move on to the anatomical variations in the abdominal vasculature. So they can be arterial origin, systemic venous origin, or portal venous origin. So based on these variations, there are several classification systems made by the previous researchers. So some classifications are used predominantly in some categories of surgeries or to interpret the imaging radiological images. That is why we extended our research scope into the abdominal vasculature. So we did several descriptive studies at the departments of anatomy, radiology and forensic medicine, Faculty of Medicine, University of Pennsylvania. So our objective was to observe and record the anatomical variations of the abdominal vasculature through cadaveric dissections, autopsies, and contrast-enhanced computed tomography imaging. So up to now, we have 5 studies. First one is regarding the portal vein, its origin and tributaries. Second one on draining patterns of the inferior mesenteric vein. Third one on variations of Henle's gastrocolic trunk. Fourth one on hepatic artery variations, and the 5th one on cystic artery origin and variations. So, if we know carefully, if we see, all these are more or less regarding the portal system. So, what about those other systemic ones? So, we will move our research scope into that area very soon. Let's go to the studies one by one. study 1 regarding the portal vein. So here we have two parts, the cadaveric study and the imaging study, which is in which the image interpretation part is not initiated regarding the portal vein. So here I have put a picture of a cadaver. This one is the portal vein. Okay, so regarding the portal vein origin, we got total of 36 cadaver specimens where we look into the portal vein origin, from which veins did the portal vein makes. So the commonest pattern is to join the splenic vein with the superior mesenteric vein to form the portal vein. That concludes 27 specimens, followed by the trifurcation. Then when we go to the portal vein branching, the most common pattern was type 1. That is the main portal vein dividing into right portal vein and the left portal vein, followed by the trifurcation. So for portal vein branching study, we used 22 cadaver samples. Moving on to the study 2, there we looked onto the draining patterns of inferior mesenteric vein. So inferior mesenteric vein that can be drained into the splenic vein, as we all know and the textbook says, or to the superior mesenteric vein or to the converse. So in our study, we looked into the 36 cadaver specimens and 14 specimens. The inferior mesenteric vein drains into the superior mesenteric vein. In 13, that goes to the splenic vein. So I think we need more samples to clearly conclude whether the more dominant pattern of inferior mesenteric vein draining into the splenic vein is the prevalent pattern in our population. Study 3, variations of Henle's gastrocolic trunk. So here we used 15 cadaveric specimens. So this Henle's trunk was present in all cadaveric samples with 7 vein combinations involving 6 different cases. So in contrast to the previously reported studies, within our study, we identified the ileocolic vein as a new contributory of the Henle's trunk. So here, the main tributary vein was right gastroepicolic vein, followed by right colic vein. Fourth study was about hepatic artery variations. Here we used 22 cadaver specimens and we looked into the origin of the hepatic arteries, and all the hepatic arteries originate from the common hepatic artery of celiac trunk. The last one, it is about the cystic artery origin and the variations. So here we used 52 specimens from cadaveric and postmortems. So the most commonest origin is from the right hepatic artery, which concluded about half of the specimens, followed by the common hepatic artery. And almost all the cystic arteries were somehow positioned in the Talot's triangle, where in 31 specimens we were able to get the relations with the hepatic ducts. So in 15 specimens out of 31, the cystic artery was positioned posterior to the common hepatic duct. So these are some of our publications. We have lucky enough to publish three abstracts, and these are the posters we have made from those abstracts, and 2 case reports so far from our studies. So what is the importance of knowing normal anatomy and anatomical variations in vessels? So normal anatomy gives the origin and cause of a vessel. So you must know the normal one. Otherwise, you can't recognize the abnormal one. So variant anatomy gives you an idea about other less common possibilities. So this normal and variant anatomy will help you to radiological image interpretation, diagnosis and preoperative assessment, treatments, then avoid iatrogenic injuries or bleeding during the surgeries, and reduce post-operative complications, and again, to produce or propose new treatment or surgical approaches. Then again, you can get new research ideas, and there are some population-based variations also. At last, I would like to introduce you our team. So together, everyone in our team will achieve more. Last, I would like to acknowledge all cadaver donors for the Department of Anatomy, Faculty of Medicine, University of Peradeniya, and all the family members of the deceased patients whose autopsy is carried out at Department of Forensic Medicine, and the patients whose imaging studies were done at the Department of Radiology. Without them, we would not have able to do any of these studies. And to the staff of all these three departments, and for you all. Thank you.
Thank you. We kindly request the speaker to please remain on stage to receive their certificate. For that, we cordially invite Dr. S. Krishna Pradeep to award the certificate. Thank you very much. And that concludes our thematic presentations.